So hello everyone and welcome to the 23rd case of this case discussion series, and we'll be discussing two companion cases today of spinal cord tumors. So coming to the first case, we have a 32-year-old male who presented with progressive quadriparesis since past 4 years and now bedridden, came for an MRI. These are the T2 weighted images, sagittal section of this patient, where we can see that the lesion is occupying the lower dorsal and conus medullaris, causing cord expansion, and there is cystic dilatation of the central canal proximally. This is T2 hypointense cap that is seen, and there are multiple foci, hypointense foci within the lesion. These are the T2 weighted images, axial section, where again we can see that lesion, heterointense lesion. These are the T1 weighted images, isointense lesion can be seen here, and these are the T1 post contrast images where it is seen heterogeneously enhancing, causing cord expansion. These are the axial images, T1 post contrast. There is no expansion into the foramina and it is causing cord expansion, and there is cystic dilatation of the central canal proximally that can be seen. So this is a report that I had given, that there was a well-defined heterogeneously enhancing longitudinally oriented intramedullary spinal lesion. So it was well defined, and it was heterogeneously enhancing because of multiple calcifications and hemorrhages within, and it was longitudinally oriented intramedullary lesion, occupying the lower dorsal and the conus medullaris, causing obliteration of the surrounding CSF space and expansion of the cord. It was extending from mid D12 to mid L2 vertebral level. The lesion appeared heterogeneously hyperintense on T2 and STIR images because of the calcifications and the hemorrhages, and it definitely showed a hypointense hemosiderin cap on T2 weighted images, which was very well seen. And there was isointense to hypointense signal on T1 weighted images, which was seen. And there was associated moderate proximal cystic dilatation of the central canal up to D12 level, causing thinning of the surrounding cord, because of which the patient had quadriparesis and quadriplegia. So it was suggestive of a myxopapillary ependymoma because of the location, particularly occupying the conus medullaris, and a lot of hemorrhages that was seen within the lesion, and because of the heterointense signal on T2 weighted images. The lesion also showed a T2 hypointense cap, and myxopapillary ependymoma is very prone to hemorrhages. So coming to another case, a companion case. So myxopapillary ependymoma is actually an intramedullary tumor, spinal tumor. And this is another case where this patient came with low backache since the past 2 months. And these are the MRI pictures, T2 weighted images, where you can see a well-defined lesion causing displacement of the cord on SAG images. These are the axial images or T2 weighted images, where again we can see this well-defined hyperintense lesion causing displacement of the cord. And these are the T1 post contrast images where there is vivid enhancement of the lesion with displacement of the cord laterally. So it was an intradural extramedullary ovoid shaped well-defined lesion at D12 L1 level that displayed the cord anterior and to the right side, and showed isointense signal on T1 as well as T2 with avid enhancement post contrast, with no extension into the neural foramina, suggesting a spinal meningioma as the diagnosis. So how do we actually approach? So this is a very important flow chart as to approach to any spinal tumor. The first thing is we look at the cord. The cord is expanded, as was in our first case. Then is actually an intramedullary tumor which causes obliteration of the surrounding CSF space and expansion of the cord. If the cord is not expanded, we look at the surrounding CSF space. The CSF space is actually expanded in the site of the tumor, causing displacement of the cord to the opposite side. Then it's actually an intradural extramedullary lesion giving a meniscus sign. If the CSF space surrounding the cord is not expanded, then it's actually an extradural tumor. So intradural extramedullary tumors include meningioma and schwannoma, and one of the case I had in my second case discussion, that was meningioma. Extradural tumors can be vertebral tumors, can be metastasis. Coming to myxopapillary ependymoma, that is our first case. It's a variant type of ependymoma that occurs predominantly in the phylum Terminale and conus medullaris, and it represents 13% of all the spinal ependymomas and most common tumor of the chorda equina region. The important sign that we have to remember is cap sign in case of any ependymoma, and particularly in case of myxopapillary ependymoma, because myxopapillary ependymomas are a subtype of ependymomas that are most prone for hemorrhage. An important sign that we can remember in this is the ginkgo leaf, where we can see the ginkgo leaf sign of meningioma, where the cord represents this is the cord, this is the cord that represents the leaf of the ginkgo, and this small stem, the stem, hypointense stem, is actually the stretched dentate ligament extending through the enhancing tumor as a stem. So the dentate ligament is actually present bilaterally and is a triangular extension of the pia mater that anchors the spinal cord to the dura. These are the dentate ligament of the ginkgo leaf. So these are the two signs of the two cases that we discussed.